Parkinson's is a cruel disease, a progressive neurological disorder that can rob you of your ability to move and eventually your ability to think as well. So let's learn more about the disease, how it's treated, and what the future looks like. I'm Lee Kelso from the Health Call Live Radio Hour, and let me welcome to the broadcast our expert for today's segment, and that is Dr. Rebecca Gilbert. She's the Chief Science Officer for the American Parkinson Association. Thank you for joining me.
Thank you so much for having me.
What is the most important thing for us to know about Parkinson's disease?
Well, the most important thing to know is that it does not mean the end of all your activities and the end of your life. It means the start of and some new challenges, but with help and with the proper medical care, you can live a full life with Parkinson's disease for many years.
So let's talk about early detection because it's a progressive disease. You want to catch it as early as you can. What are some of the earliest warning signs that people might not recognize?
Right. So very interestingly, as you mentioned, it really is characterized clinically as a movement disorder. So it affects how you move. It can cause tremor, slowness, stiffness, problems with walking. But in fact, there are what we call the non-motor symptoms of Parkinson's disease, which can be very problematic as well. And it turns out that a few of those non-motor or movement problems can happen very early. There's a constellation of those symptoms. We think of 4 symptoms. One is REM behavior sleep disorder. And what that means is people who have the tendency to act out their dreams. That's one. The second is constipation. The third is depression and anxiety. And the fourth is decrease in smell. And these 4 elements can happen really early on in the Parkinson's disease course. But of course, those 4 things that I just mentioned are common in the general population as well. And so it is a trick to figure out whether you are one of those people who will proceed to develop Parkinson's disease if you are developing these early signs. And so if you are concerned that, those 4 things sound familiar, I would make a non-urgent appointment with a neurologist and see if there's any neurologic signs that are developing as well.
Okay, man, lots to go back and revisit there. So what is this acting out dreams, this REM sleep disorder? Tell me how I might recognize that.
Yeah, so normally somebody who is sleeping and dreaming actually has this mechanism in place where you're paralyzed. So people usually are paralyzed during their dreams and so can't move. It turns out that a certain part of the population has a disorder called REM behavior sleep disorder where they're not paralyzed in their dreams. And so they can act them out. They can move their arms, shout out, sometimes hit their bed partner, fall out of bed. If these things happen, the person dreaming may not be aware at all because the dream is taking place as if it's a dream. The person who will know that there's a problem is the person sleeping with the affected individual, and will alert the person. Hey, you're shouting, you're hitting me, and so that's really where we get the information that this disorder is happening. And again, this is not an uncommon thing to happen.
Okay, so if that weird sleep behavior is paired with constipation, that adds a layer of concern. How do I know constipation associated with Parkinson's versus kind of something else?
We really don't. So early on, if you have constipation alone, or let's say in constellation with some of these other things I mentioned, there really is no way to know for sure whether this is a precursor to Parkinson's or not. So I don't want to alarm everyone listening that if you have constipation, you have to worry that you have Parkinson's disease. It really is a part of a whole package that really needs to be assessed eventually by a neurologist.
And that loss of sense of smell, something we've come to become familiar with, I think, through COVID, but stacking up all those risk factors. And of course, if you have somebody in the family who has Parkinson's, that's also
exactly. So, what I've mentioned up till now are signs that Parkinson's may be developing. But in terms of a person's individual risk of Parkinson's disease, it really is just like every other chronic illness, a combination of different factors that either you've been exposed to environmentally or genetic factors, and some combination thereof, which leads to the development of a chronic disease such as Parkinson's disease. So certainly in the setting of particular environmental exposures and a specific genetic risk, then that all goes into the mix about how concerned one should be about Parkinson's disease.
So, what would a neurologist do to move forward and identify early onset of this disease?
So at this point, Parkinson's disease is a clinical diagnosis. And so certainly we'll take a detailed history, would ask about all the non-motor symptoms that I mentioned, would ask about family history, for example, and then would perform a neurologic exam to see if there's any subtle signs of Parkinson's disease. And the subtle motor signs may be things like not swinging an arm on one side or having a stiffness that's asymmetric one side more than the other. There may be a small bit of a tremor that a person hasn't noticed, although people tend to notice tremors. They may walk with a bit of a stoop. They may have a bit of asymmetry in how their legs move. So these sort of subtle signs will be part of the assessment to see if the neurologic piece may be peeking out as well, and it isn't just the non-motor symptoms that a person has noticed. Sometimes what happens is it's very, very obvious to the neurologist that there are neurologic signs and those haven't been noticed by the person. So a visit to a neurologist makes sense.
Always makes sense. So, what do I do in those earliest of stages, or is there anything I can do in the way of prevention?
So unfortunately, we do not have a medication right now that prevents or slows down the progression of Parkinson's disease. And this is really a research goal that's really top of mind throughout the field, because that's what we need to find. The brain is a really complicated structure, and most likely, or we really know already, that deterioration of the nerves in the brain occur very, very slowly and start decades before a person even has symptoms. And so the processes that we're trying to slow down and stop have really, they have the lead over us from when we notice things. And so that really makes prevention and slowing progression very difficult. Having said that, there's a lot of research that's trying to work this out. Until then, one of the primary elements that one can do to try to slow down the deterioration of nerves in the brain is actually exercise. There is evidence that exercise does a whole host of good things to the brain. It may increase blood flow to the brain. It may increase nerve growth factors to the brain. It may increase the ability of different nerves to talk to each other. It may increase the ability of new nerve sprouts to be produced and reach other neurons. There are different things that have been shown in research that exercise can promote. And so that is really one of our primary messages to all our patients, especially the early people with PD, Parkinson's disease, is to exercise and get that brain as healthy as possible.
Does it matter what type of exercise, since it's a movement disorder and muscle stiffening becomes one of the main symptoms? Is aerobic exercise enough? Do I need to do strength training? Is yoga effective? What really seems to work?
Right, so that's a great question, and we don't have all the answers. We don't have clinical trials that really pit every kind of exercise versus every other kind. We do know that aerobic exercise is very important, and certainly following the CDC guidelines of how much aerobic exercise and older adults should have or get every week is really a great starting point. And so that's something to anchor yourself in terms of guidelines. But all the different types of moving are going to be important. So that would include strength training, balance training, stretching as well. And then another element to consider in Parkinson's disease is in some forms of exercise, there is a motor learning component. So your body is used to doing certain things. Let's say you go on a treadmill and your body can move your legs in a certain way. But if you take on a new kind of motor activity, like learning a new kind of dance or learning a new kind of boxing or martial arts technique, that may have an additional benefit of incorporating a cognitive element into the exercise. And so there are a lot of programs for people with Parkinson's that incorporate that element as well, that motor learning element.
Yeah, the brain loves to learn. Yeah, isn't that fascinating?
It really is.
So let's talk about. So currently, the gold standard of treatment is a drug, levodopa, that is designed to enhance dopamine production in the brain. I guess we never really identified that your body's inability to produce dopamine is what they believe now is associated with muscle stiffness and the loss of motion coordination. So trying to increase that dopamine output is the goal of that particular medication. I understand it grows less effective over time, and Parkinson's is not a disease that's going to kill you. Most people die with Parkinson's disease, but from something else, correct?
That is correct. In terms of levodopa and its effect, so exactly as you said, the at least the motor symptoms of Parkinson's are due to the loss of nerves in the brain that communicate with each other using dopamine. And this lack of dopamine can lead to these motor problems. And so finding ways to put the dopamine back in the brain is one of the primary goals. And so taking levodopa is really taking dopamine. Levodopa is a precursor to dopamine. It can enter the brain, whereas dopamine itself cannot enter the brain. And so we give people the precursor, it can get in the brain, and then it turns into dopamine once it's in the brain. The issue isn't so much that it stops to work. The issue is that there are fewer nerves in the brain to work on. And so, or I should rephrase that, it's the actual disease is progressing as you're continuing to take the medication. And so you need to adjust the dose as you go to make it continue to be effective.
I appreciate that correction. So, with that in mind, I am reading that stem cell therapy is holding some promise. So, in essence, we're taking stem cells and training them to be the cells that produce dopamine and implanting them in the brain. Did I get that right?
Right. So, there are a lot of efforts along the lines that you discussed, and the new innovations that's been pushing this field forward in the last number of years is the fact that scientists have learned how to take a fully formed adult cell and de-differentiate it in a laboratory, and then ask that de-differentiated cell, which is now a stem cell, to become a dopamine cell. So it sounds science fiction, but you can actually take fibroblasts or skin cells and make them into neurons, which is kind of amazing. So we don't have to get those precursor cells from fetuses anymore, although there are lines of research that may continue to do that. Primarily, the field is working on what's called induced pluripotent stem cells, taking adult cells that are already fully formed into one kind of cell and pushing them back in the differentiation process and then into a neuron. And so this has really opened up the field tremendously, and using these new cells to then populate the brain. This is not prime time. It's a lot of research that still needs to be done, and it is really only one research avenue to try to move the field forward, but it's a very exciting one.